All right, and my email's at the bottom, and if you have comments or questions or want to contact me, feel free to contact me at larry.lands@mcgill.ca. All right, and we'll try and ignore that. Okay. All right, so when we're using oscillometry, we, I'm not sure why it's not showing. Then what you have is on top of a patient's quiet breathing, you have these oscillations that are imposed on top of it by the oscillatory device. And so you get a signal that you can see on the bottom here that has the superimposed oscillations on the normal breathing. And these give rise to, you can see both the breathing pattern and respiratory mechanics, specifically impedance, which then can be broken down to its components, which are resistance and reactance. And I'm going to not talk about the mathematics or the engineering behind this, but we're going to talk about how to use this. So, see how I can put this in place that it's not going to bother us. Sorry about this. Let me just minimize this. Okay, then. And so you'll see different waveforms. You can have a sinusoidal waveform. This is at a single frequency or monofrequency. Many of the devices that are available in the market will use a pseudo-random noise. So it's still a sinusoidal, but at multiple frequencies in a random order. And then you can have iOS devices, which will give a square wave at a fixed frequency. Generally, those are 5-second blocks, and it occurs at a frequency of 5 hertz. And so from that, okay, sorry about that. From that, finally we can move this. Okay, sorry about this. Good. From this, you can get resistance. This is the resistance curve versus frequency. You can get resistance at low frequencies. Typically for children in school age, will start at a lower resistance of 5 hertz. Younger children who are breathing quickly, we might use a resistance of 7 hertz. It's a lower. Then we will look at a measurement further down, usually at 19 to 20 hertz. That's for the resistance curve. And you will see that in health, there is no, FDR is frequency dependence. There's no change in the frequency, in the resistance with frequency. You also have the reactance, the other components of impedance, and we have the reactance at 5 hertz. We have a resonant frequency where the reactance due to the capacitance component equals the reactance due to the inertance component, and so they cancel each other out. And so we get it, and then we can get the area under that curve, which is known as the area of reactance. And that is more related to elastic properties, quite sensitive to ventilatory immunogeneities, and so it can detect both obstructive and restrictive defects. And so if we focus first on the middle panel, which is a healthy subject, you can see that there really is no change in resistance with frequency, so it's frequency independent. You can see that the reactance at low frequency is quite small. The resonant frequency occurs fairly at a low frequency, and so the area is quite small, and there's no change. Here it was using a methacholine challenge. See, on the other hand, with a patient who has asthma, pre and post broncho or with methacholine, you could see that the resistance at low frequency goes up. You can now see that there is a dependency of the resistance as the frequency goes up, so it goes down. So there is a difference between the resistance at, let's say, 5 hertz and at 20 hertz. You can see that the reactance at low frequencies is significantly lower than pre-methacholine. The resonant frequency has markedly shifted to a much higher frequency, and so that the area under that curve, or the reactance area, is much larger. And you see here in a situation compared to a healthy adult subject with again, no dependence of resistance frequency, you can see a higher resistance at 5 hertz, a big difference between the resistance at 5 hertz and 19 or 20 hertz. And now the reactance is much more negative compared to health. The resonant frequency, again, is shifted way up. And so the area under the reactance curve is much larger. I will caution you that different devices have different normative values. So unlike spirometry, there has not been standardization in the oscillometry world as yet. And so you, depending on the device you use, and here it was tested using a mechanical device, there is a difference between devices. So when you're using predicted values for a specific device, you need to utilize predicted values for that device. Similarly, Francine Ducharme, when she studied children with different devices, you can see that there was a marked difference between devices. Here, just looking at the resistance at 5 hertz, you can see that different devices gave different predicted values. What that means is that if your patient is tested on different devices from different manufacturers, you cannot compare or trend the results between the different devices. There is a move afoot to try and standardize that and harmonize that, but it's not available as of yet. So how to perform oscillometry? So the cheeks need to be supported. I'm not sure why both the subject and the technician look angry, but the cheeks do need supported either by the technician or by the subject themselves. It's important that the subject is relaxed. They have to make a good seal on the mouthpiece, and you definitely want to avoid putting your tongue in the mouthpiece because that will affect things. And then you want to have them quietly and relaxing breathing at a normal respiratory rate and a normal tidal volume before you start doing measurements. So in terms of how many breaths do you need to capture when you're doing it? This was a study in children, and generally you need to do at least 5 breaths. Doing more, it can be done, but it's not necessary to do. The other aspect that's very important for getting a good quality signal is you have to do at least 3 trials. Generally, it's 3 to 5 trials, and people will often pick out the 3 trials that are most similar. But the way quality assurance is assessed is the coefficient of variation at the R5 or if you're using R7, the lowest frequency you're measuring the variation between the trials. And so that coefficient of variation needs to be at most 10% in adults. The literature suggests 15% as an upper limit of the coefficient of variation. So that's the standard deviation between trials over the mean of the trials. They accept up to 15%, but really most people utilizing oscillometry in the field would really prefer to have a coefficient of variation of 10% for children as well. This was a study. Now, they only did 2 acquisitions, not the 3, but you can see here's the 15% cutoff coefficient, and you can see the vast majority were under 15%, and even actually the vast majority were under 10%. And that's really what we should be heading for. And this is talking about variation between trials. So is it feasible to do in young children? And generally, this was with 1, and here is with doing 2 trials. It's generally reproducible. Very easy to do in the school age trial, the 6 to 12-year-old. In the under 5-year, the 3 to 5-year-old range, it can be more variable, but still you can generally get a pretty good measure just by doing 1 and really feeling a lot better. Really, in doing 2, preferably 3, but it is fairly reproducible with your technicians or yourself getting properly trained in technique and coaching. You can really get measurements out, even in young children as young as the age of 3. This is showing some reproducibility within a session, and you can see that really this is our Blandin-Altman plots. We look at the bias between measurements, so how much they're off, and really if they're reproducible, it should have a bias of 0. But it also points to the limit of agreement, and the limit of agreement are pretty tight, so which is good to know. So within session, it is fairly reproducible. This was a study looking at, as you can see, young children, 2 to 7-year-olds, and reassessed them 7 to 14 days apart. And you can see that certainly for the R5, which is what we have been looking at for a coefficient variation, it's really quite small, so it is reproducible over a time period. You can see that other measures, particularly the reactance measurements, can be a little higher in terms of their variability, but you can use these to follow patients. This was also looked at in adults. These were 75 adults who were considered to be stable over a period of at least 140 days. And you can see that the percent change between the time points was really quite small, certainly for resistance, a little larger for the reactance measures. Notice there was some variability as well with pheno measures. But if you measure in Z scores as opposed to percent predicted, again, the variations were small. So if your patients are stable, you do expect fairly stable numbers, and you can use these to track your patients. So in terms of what do we consider normal? And in general, and there are 2 statements that have come out, and I'll show you on the next slide some further data that's come out for adults. But generally, we have an R5 that's 0.8 to 1 centimeter and with an area on the reactance curve of 8 to 10. So that's that area under here. And for a bronchodilator response, we're talking somewhere between 30 to 40% for adults and children if you're using resistance. Reactants, you want a change of around 45 to 50%, and the area on the reactance curve, these statements, including the ERS statement, really talk about more than 80%. Now, a more recent paper, really published in 2025, Utilize the studies that the ER statements used, but have added in some more recent studies, one with close to 1,500 and one with close to 600 patients. And you'll see that these are fairly similar to what I just showed in terms of bronchodilator threshold. It would be a 30% drop in the R5, 45% further decrease in the X5, and the area under the reactance curve of increasing or decreasing by 65%. So a reduction in the X5 by 45%, a drop in the resistance of 5 hertz of 30%, or a decrease in the area of the under the reactance curve of 65% would be considered cyclic bronchodilator response. Just as a reminder, these are what I showed before, and so we're in fairly close agreement here. Now, bronchoprovocation testing is a whole nother story. This is from a recent review by David Kaminsky. There are some pediatric data, but I will strongly endorse their summary statement that cutoff values for clinically meaningful results have not been fully established. Here's a more recent paper, but note it's like 25 patients, but still it did point to cutoffs in terms of percent predicted before you would consider that they had a positive bronchoprovocation test. At my hospital, we've typically used a 50% increase in R5. That was based on Lebeck's patient paper. Again, small sample size. The reason we've done it is this was done at our institution, and we haven't really gone back and revisited. But as you can see, most of these have used a very small sample size. This one was at least reasonable size, and they used as a 50% decrease in the reactance at 5 hertz as being a positive response. And these are not unreasonable to use. Just let me mention, at the end of the presentation, I do have my list of references. I could send these to you. If you have trouble getting hold of these references in your local center, please feel free to email me, and I can email you a PDF of those papers. So let's look at some real stuff. Here's a healthy child. The pre-bronchodilator is dark, and the lighter blue is post. You can see there really is no frequency change with the resistance. There's only a 14% decrease in the resistance at 5 hertz. You can see that the X5 is low, and the resonant frequency is relatively low, and the area on the reactance curve is small. And there was very little change with bronchodilation. You know, if you look at either the X5, the resonant frequency, or the area under the reactance curve. Here's a child with who responded to bronchodilators, and you can see that there's a nice big decrease in the R5. We actually had a 49% decrease in the R5. We had the X5 go up by decrease by 49%. Remember that the reactances are negative, so a negative decrease is a positive, so it went up by 49%. You can see that the area in the reactance curve, so you had this pre-bronchodilators, whereas now we only have this post-bronchodilators, was actually went down by 80%. So this would be a significant bronchodilator response. There was one small paper that compared patients who had laryngeal obstruction. So, you know, we're always faced with that problem. A patient comes in with dyspnea, possibly patients have heard wheezing. Is it really upper around the laryngeal obstruction, around the vocal cords, or are we talking about lower airways disease? And oscillometry can actually help you. Um, the not really in the R5 and a little bit in the R5 to R20, but where and the arrow points to this unfortunate outlier, so let's ignore that point. But you can see that the reactance at 5 hertz and the area on the reactance curve really help differentiate an asthmatic, the asthmatic population from those with laryngeal obstruction, whereas the area on the reactance curve was larger in the asthmatics, and they had a lower reactance at 5 hertz. So it can help you in terms of differentiating. It actually was indicative as well as asthma control or use of medications in pediatric asthma. Here, the resistance bronchodilator response was quite different in those those who did not respond to their asthma medication had a smaller response than or those who did respond had a smaller bronchodilator response when they come to clinic versus those with ongoing medication needs had a bigger bronchodilator response. You can also see here again with looking at reactants, post-bronchodilator, and resistance was also helpful. This was preschool. This is in the school-age child. You'll notice that in the school-age children, when they used FEV1, it really didn't indicate between those who had no ongoing medication use or those with ongoing medication use, pointing to that oscillometry can be more sensitive to picking up towards ongoing medication use. And I'm going to show you some slides with related to uh, uh, asthma questionnaires for control. So the resistance, now this was a monofrequency study, so they just measured at 8 hertz. And basically, if your resistance at 8 hertz was above the upper limit of normal, you had ongoing medication use. Oscillometry can help you track patients over time and predictive of abnormal oscillometry when they're old, or spirometry when they're old enough to do it. So this was looking at spirometry age 8, and they basically had 3 cohorts where they had those who started off actually somewhat above normal, those who started off normal, and those who started off low. And if you're low at younger ages, especially if it persistently stays low, you are going to have low spirometry. Take your favorite measure, FEV1. It was certainly quite sensitive to resistance and reactance and the area under the reactance curve. So it's worthwhile tracking and point towards those who, when they're old enough to do regular spirometry or standard spirometry, that you will see that there's ongoing differences. And using the ACQ, talking about those who were well controlled versus poorly controlled, you can see using spirometry, there was really no difference in these measures. However, oscillometry was really quite different. The poorly controlled had a higher resistance. Uh, they had a more negative reactance, and their resonant frequency was also larger in absolute and predicted terms. Notice pheno only trend, so that again, this points to that oscillometry might be much more sensitive in picking up how well your patients with asthma are controlled. And note that these patients, even in the poorly controlled, they really had, for all intents and purposes, these are values in the normal range. And so you might not be able to just rest comfortably just because your spirometry is normal. carrying on from that, they actually, when they combined FeNO measurements, so that's fractional excretion nitric oxide measured at the mouth, with oscillometry measures, the predictive value of asthma control actually went up across the board. And so combining oscillometry with FeNO can be quite helpful in the children with asthma. Similarly, the odds ratio of having abnormal oscillometry, of having poorly controlled or asthma was significantly high. You can see much higher than just predicted by having an elevated FeNO, that these odds ratio are significantly elevated even after adjusting for sex, age, BMI, smoking, and seasonal aspects. So again, also pointing to oscillometry being a helpful guide as to how well patients are controlled. I know some of you are treating adults. So this is the Atlantis study. This was the largest study of asthma control in adults, and they combined 3 measures of oscillometry: the area under reactance curve, percent predicted, the R5 to R20 percent predicted, the difference, and the X5% predicted. They combined it and they came up with some ordinal scale. And this was quite predictive of an increase in exacerbation rate. So here again, oscillometry is helping to indicate who is well controlled, who is most likely to have an exacerbation. So I think you can combine these measures, and not necessarily use a single measure, but you can combine these measures to try and indicate to you patients who are at risk for exacerbation, and focus a little more on them on optimizing their treatment. Further on from the Atlantis trial, they looked at area under the curve, but also predictive value, and just adding in using parameters of age, age of diagnosis. This was looking at and BMI, and using an 8-item score of small Aries disease. Wasn't all that predictive. When they added an FEV1 in terms of diagnosis of small Aries disease, the predictive value went up, but the LR, which is really gives you what's the likelihood that there's a likelihood ratio, so likelihood that this is occurring, again, was relatively low. However, when they added in oscillometry measures, in this case, the R5 to R20 difference and the area under reactance curve, the area under the curve for prediction and the likelihood ratio was markedly elevated. So these can add to spirometry. I'm not saying throw out spirometry. I will tell you, speaking to my colleagues who look after a lot of adults, and I can even tell you in children, spirometry requires taking a big breath and doing a full exhalation. It might provoke cough. People don't feel comfortable doing it. They're quite tired. In terms of if you're only going to do one test, and if you ask the patients which one they preferred, they would prefer oscillometry. This is a study that I've always appreciated. It was done in children who did not have well-controlled asthma on a standard dose of inhaled corticosteroids. And so they randomized them, and in theory, all children were going to try all 3 things. One was doubling the inhaled steroids. One was adding in a LABA, or long-acting beta agonist. And the third was adding in a leukotriene receptor antagonist. And the thing is that everyone responded to at least one, which is good news. But the trickier question is, could you predict which one which patients were more likely to respond to which treatment. And so again, so here they looked at a few things. They looked at their provocative concentration to methacholine, a 20% drop in FEV1, the asthma control testing. They looked at some genotyping. They looked at pheno, and these really weren't all that helpful in telling you which treatment should I pick when I want to augment my asthma therapy. But they did a follow-up study, taking the same data, but they included oscillometry measurements. And I don't expect you to read all this. It's all sorts of things. But what I want to say is that when they control for baseline FEV1, the FEV1 to FVC ratio, urinary leukotriene levels, age, baseline oscillometry resistance, and area under reactance curve. After controlling for all these things, which are things you think about controlling for, the area under reactance curve was predictive of those who are going to respond to a long-acting beta agonist and help you select out for this particular patient, because it's wonderful to talk about populations and groups, but what you have in front of you is a patient. Here it was an indicator that maybe for this particular patient who has this change in AX, or that they are more likely to respond to using a long-acting beta agonist. So some other things. This was a compilation. On the table here is a compilation of several studies to try and predict who was going to respond to a biologic. And largely, if you were going to respond to a biologic, your oscillometry values were more closer to normal, or you're more likely to have normal values. Whereas if you had abnormal values, you're more likely to not be a responder. And I've heard this said before when people present on biologics, that the people who respond the best to biologics are those who already have pretty good lung function. You hear oscillometry was really quite helpful in indicative of that. Notice that air trapping and the FEF 2575 really wasn't helpful, but the oscillometry measures did, as well as a composite measure. And here was a study that looked at patients with mepolizumab over 6 months, and they compared them to healthy controls and a group who were well controlled. I want to point out to you, if we look at the dark green bars, at baseline in 6 months, there really was no difference in FEV1. So if you were expecting to see an FEV1 difference, you weren't going to see it. Could see, and I want to also point out that you can see that things really look quite stable for those who are well controlled and people who are healthy. You can see that there was a small decrease in R5 in the people who were put on mepolizumab, but really what you could see is nice big difference in the people who were on mepo in their between baseline and 6 months in their R5 to R20, their resident frequency, and their area under reactance curve. I also want to highlight well-controlled asthmatics. Notice it didn't change over 6 months. Give you some comfort that these subjects not only seem well controlled, but that these values are reproducible. Similarly, in the healthy population, you can see that these are fairly reproducible. So here we had where they couldn't pick up a signal that mepolizumab was doing anything in this asthmatic group in terms of FEV1. They were able to see oscillometry, which is more sensitive to changes in the small airways of response to a biologic. And, there's been so few head-to-head challenges in biologics, and I'm always saying, when am I going to see the Pepsi challenge, see one biologic or another? Because you're always confronted, which biologic do I pick for my patient? So here was one study. It's in adults, 12 weeks apart, and they compared benralizumab to dupilumab. I can see that actually and this is their Y scale is the percent improvement. Okay, so 0 means you didn't improve, and you can see that the benralizumab group really didn't change over the 3 months, but the dupilumab group, you got an improvement in their R5 to R20, their area under reactance curve, suggesting that that this could actually be helpful again in trying to decide, are my patients responding to a biologic? Is this the biologic I should use? Creates a small sample size. It's a short-term study, but it's just pointing to that oscillometry can be somewhat helpful. I know that some of you, just to move a little bit away from asthma, there's a study we did in obese adolescents, and you can see that, yes, while there were differences or trends from our healthy control group, you can see that they really did have normal spirometry. But you can see that their percent predicted oscillometry, especially R5 to R20 and the area under reactance curve, were markedly, were not only different from the control group, but were markedly elevated. And again, it helps detecting small airways disease in the obese population. Many times these patients do present with shortness of breath, dyspnea and exertion. People always wonder they have asthma. This small airway disease might be related to them being at smaller lung volumes and having airway closure. AX is particularly sensitive to airway closure. We could talk a long time about the physics and the mathematics behind oscillometry, but the responses, the changes are much more sensitive to closing off airways rather than thinking of airway narrowing. Here is a study done in adults, and you can see that between those with a BMI that's under 30 and those that are over 30, you could see that the FEV1 percent predicted really was not different. And, but there was a difference in FEV1, FVC. And here again, though, you could see that the oscillometry values really picked up differences. So again, spirometry is not sensitive to small airways. You have to knock off about 50% of your small airways to see a change in resistance and start noticing in your FEV1, whereas oscillometry can pick some of that up. Oscillometry is also sensitive to symptoms. So this is quite a large study. You can see they had over 2,000 patients. These are subjects. These were an adult population out in the community, and there was a certain segment who had abnormal spirometry, but you can see that there was a higher proportion that had abnormal oscillometry. Okay, again, speaking to sensitivity, you're going to say, yeah, does that really matter? So here's where it mattered. And I invite you to take a look at this paper. The more symptoms you had, the more likely you were to have abnormalities in reactance at 5 hertz or the area on the reactance curve. And so, again, it's sensitive to picking up symptoms. And these are people who are being, just wandering around in the community. It's quite sensitive to picking up differences in severity of COPD. You can see how from health where there's no frequency dependence of resistance, you can see that the the resistance at low frequency is high, and the difference between 5 and 20 is quite large. Again, you can see that the reactance becomes much more negative. The resonant frequency, they don't have a line here, but you can see that it's shifted over, and of course the variance in the reactance curve. So again, in terms of classifying your patients, and there is some work, I'm not sure if it's been published, but certainly there's some work that in terms of gold scoring, in terms of matching it with CT scan changes and symptoms, oscillometry seems to be more sensitive. We're starting to explore this now in cystic fibrosis. You can see here's a patient with totally normal spirometry, yet their area on the reactance curve, so this whole area here, is markedly abnormal, and it speaks to small airways disease in these patients and ventilatory inhomogeneity. There has been studies, and here this was a study done by somebody else, and they didn't just have patients who were normal spirometry, but they found that if the resonant frequency had an elevated Z score, then you were more likely to have an elevated lung clearance index. A lung clearance index is a somewhat complicated test. It takes about an hour. You need very specialized equipment, and basically it's a nitrogen washout, but you're looking at how long it takes to clear that out after the patient has breathed 100%, how to clear out nitrogen after breathing in 100% oxygen. So it's time consuming, it takes time, it takes quite expensive equipment, it takes technicians who are very well trained. Oscillometry is quick, as I showed you. You need about 5 breaths repeated 5 times. Equipment is less expensive, and there's less technical training involved. I'll just throw this in. This was a study we did at adults, and even those with relatively good lung function, still a lot of them had markedly elevated area on the reactance curve, again pointing that it might be more sensitive. And we are exploring this right now in our CF population. So to summarize, oscillation can be used at a young age. Certainly, I would start with 5 and above, but once you feel comfortable, you can go down to the 3 to 5-year-olds. Sometimes having them watch a video can be helpful, and certainly very helpful in those who have difficulty with spirometry. And both children and adults. I work actually in an adult lung transplant clinic, and I can't tell you how poorly patients perform spirometry. And there's evidence that oscillometry actually is more sensitive to detecting episodes of lung rejection compared to spirometry. It can pick up ventilatory inhomogeneities, even in the context of normal spirometry, so early or mild disease. It is sensitive to patient symptoms and asthma control. You can detect bronchodilation and bronchoconstriction, and it also can have prognostic value, certainly in information in children in predicting lung function using standard spirometry. So I'm going to end there. There is a survey QR code that we would appreciate if you could go through. And I'm going to stop the presentation there. I do have the references, but I'm going to stop the presentation there, and if it'll let me. And sorry. And certainly I'm open to questions. Sarah, I'm not sure if we want to do this through chat or how you'd like to do this.
Yes, so questions could go either through the chat, or we could use the raise button up above, and we'll take the questions as we go. I did unmute, I did allow everybody to be able to unmute their mic, so please feel free to either use the chat button or raise your hand, and we'll answer.
Hi, good afternoon. I have a question. Oh, sorry. I didn't raise my hand.
Go ahead.
No problem. Go ahead, Pierre.
Yeah, I'm a pediatric pulmonologist, and I was very interesting. Thank you very much for everything you presented. It was so useful for my daily practice. I'm not using yet the resistance in my practice, but I was wondering, when I was resident, we used to use it to diagnose children having cough variant asthma, not real asthma. They didn't have episode, but they were presenting at our clinic for cough mainly, without obstruction, without episode of acute exacerbation. And you know, in pediatrics, we have a lot of these kids coming for chronic cough. And so I would like to have your opinion about the utility and the usefulness of the resistance oscillometry. What do you think?
So I didn't put it up for the sake of time because it was a wide audience, both children and adults. But the child with cough variant asthma, is this asthma? It is clinically just about impossible to tell the difference. Also, there are papers out there showing that cough variant asthma can be diagnosed using oscillometry. I would, both not only at baseline but check their response to bronchodilators, and just to underscore, it's not just a resistance. You also want to measure the reactance measures as well, and you get out both automatically when you do oscillometry.
Okay, thank you very much. Thank you.
Pierre, I don't know if we got to your question.
No, yes, thank you very much.
Okay, okay,
You
that's
answered
great.
very well to my question, and I think I'll go for it. And effectively, the bronchodilator response is the most important thing. In these small children, less than 5 years of age in general, we cannot do reliable spirometry for them. So it's a good method to diagnose. We use actually what we do. We go for a trial treatment with inhaled steroids and codilator for a week, and we monitor the response, and this is how we diagnose asthma in children.
Exactly, and it's not unusual that we do trials of medication, but this can hopefully avoid some of that. Yes, if you're going to do oscillometry and spirometry in the same session, I should have mentioned that. You need to do the oscillometry first. The large breath in all the way to total lung capacity causes a volume reset. And so, yes, you have to do the oscillometry before spirometry. The other thing I'll mention, and this has been a problem with the studies that have tried to come up with the equivalent for what's a positive bronchoprovocation test, is that most of them have done, actually all of them, including the study, the Lebrecht study we did, have done spirometry in the same session. And there was a recent paper that actually compared within session to doing a separate session and found that the oscillometry values were different for doing bronchoprovocation testing. So I think significant studies, good sized studies, need to be done comparing oscillometry with spirometry to come up with cutoffs, but they should be done at separate sessions, probably in a randomized fashion. I'd be more than happy to help design such a study, but it's needed both in children and adults, and I think it will be very beneficial to the community.
Thank you.
We have a couple of questions in the chat. Could you please highlight about normal graph pattern, as sometime when we take 2 or 3 reading, there's clear variation and lots of gaps between first and second graph?
Okay, so that is why now you're going to try and do a standard technique, hands on the cheeks, breathing quietly. You get them to breathe quietly before you turn on your device. I really do insist on a low coefficient of variation. Like I said, it's up to 15% in children, 10% in adults. That's between trials. So if you're doing 3 to 5 trials, I think once patients get used to doing it, your coefficient of variation gets quite small, and you probably only do 3 trials, and you can take them off of the leave them on the mouthpiece and do it again rather than coming off and on, because I think that's some of the variation. But it's just like, if you look at ATS-ERS criteria for spirometry, they want 3 measures that are reproducible. If not, it's not reliable. And I strongly agree. I've always said I'd rather no numbers than unreliable numbers. So you really want to pay attention to that variability and make sure that it's good. I see and Sarah, feel free to jump in, but I see, is it R5 or R7? So
Yes.
the natural breathing frequency of the child or the patient comes into play, can interfere with the measurements. Generally, you want the measurements to occur at a frequency at about 10 times their breathing frequency, and so that is why it's recommended in the 3 to 5-year-olds. People typically use an R7, whereas because young children breathe faster, and over the age of once they're in school, you can probably use the R5. But like I said, the trick is get them to breathe quietly and regularly on the device before you push the button to go. And just in terms of like I said, different devices have different normative values. It was on one of the slides, but I just want to underscore the oscillometry values are not normally distributed. And so we've been using percent predicted, and yes, spirometry generally is more normally distributed, but there again, we've gone towards Z-scores, and this is what's happening in the oscillometry community. And so people are going back, looking at their normative data and recalculating Z-scores. I know Francine Ducharme is doing that in children. I think she's doing it for the Tremoflow device, but I can't be 100% sure if it's the only device she's doing. But I think we're going to move towards Z-scores, and that will allow really describing your patient. Are they within normal limits or not? And then we can talk about, changes in Z-scores as being significant or not. But that's, I think, where the community will be going over the next year or two.
One more question from Barbara. Doctor, in your opinion, how does oscillometry add value in clinical practice, and why should a physician consider adopting it?
Okay. It partly depends on the population you're seeing, but certainly if you're having a lot of patients who have trouble with spirometry, and I'll put both children and adults in that category, that I think can be quite helpful. I think if you're dealing with a population who is at risk for small areas disease, but you're not seeing in spirometry, can be quite helpful. So I think in using it in an asthma clinic, especially a severe asthma clinic, and looking at control, where we are actually just introducing regular oscillometry in our pediatric severe asthma clinic, because are they as good as we think they are? And also, especially if people want to start talking about remission or weaning, this can be helpful. As I showed you, it can be predictive of them having exacerbations, medication use. So I think it can be quite helpful in those populations. It's also, some of the devices really do not require a lot of technical expertise, relatively easy to calibrate. So they can be much more available. I didn't say they're given away in terms of price, but they can be more available in clinics. Certainly where I am in Canada, the vast majority of pulmonary function laboratories are within hospital settings. This could allow really going out to the community, which is the desire of everybody, that we have more availability, more access to lung function testing.
Okay, and last question, how much is subjective variation if we do test in same subject on different time in a day? And how to identify, sorry, go ahead, and that's the one more question, and that'll be.
Okay, that's a great question. I can't tell you that's a good measure. There is some diurnal variation, just like there is in spirometry. I can't quote you offhand how much variation there is.
Perfect. And I think that's all we can wrap up the session. Thank you very much, Dr. Larry Lanz, and everybody who had attended this session. And do you have any last words, Dr. Larry?
No, I would say, I thank Chairman Flo for this opportunity. They will have my presentation. There's a full list of references. There is a recording. If you personally can't get a hold of the references and you want them, just feel free to email me.
Thank you very much. Have a good day, everybody.
Okay. Bye.